this week on the BackTable podcast.
I think we do a really poor job teaching people what reproductive surgery is and how to do it and how to do it well and how to avoid injuring people so that we don't make their path to fertility more challenging. Certainly, our residencies don't do a great job teaching the ins and outs of reproductive surgery. And I would even argue that our fellowships don't consistently do that, although I know we've improved our educational milestones within the fellowships to really include fertility management in just about every category, whether it's fibroids or endometriosis. But I think there is a huge disconnect between most people that do surgery and actually a real focus on how do we help people get pregnant.
Once again, we have a great guest, but especially fun for me because I've got an old friend who's on the show with us today, Dr. Jim Robinson. Jim, welcome to the show.
Thank you, Mark. It's good to be here. Thanks for the invitation. I was thinking about this. We go back a long time, and I was thinking, from flash mob to podcast, we've come a long way.
And there have been a number of other things. Yeah, that was your peak. I certainly have come a long way, but no, you and I have many good stories and hopefully many more to come. No, I was a resident at the University of Chicago where there was not a lot of MIGS happening outside of getting to work with Chuck Miller a little bit, and I hadn't done that yet. And I came to AEGL, and Jim was like, "Hey, we're going to go hang out," and just sort of like said, it was just it's very, I think, consistent with how most folks are at AEGL in general, but there's a handful of you specific guys that really do identify young people and say, listen, come on, let's go, be a part of this thing. And it's super fun. And yes, we have a lot of good stories, but also just getting us plugged in with things. And so I'm forever grateful for you for that. And I mostly enjoy our friendship, but a good mentor as well. I hate to make you feel old or anything like that, but you are that too.
I am getting old, yeah, exactly.
Jim joins us from Washington, D.C., the metro area. He's currently at Shady Grove Fertility. Tell us a little bit about Shady Grove Fertility and what you do there and sort of as we do for most of our guests, we like to have our listeners hear sort of how you got to be where you are.
Yeah, no, it's been sort of a interesting circuitous route, but currently I'm the director of reproductive surgery at a really big reproductive endocrinology group, Shady Grove Fertility, which has got over 90 reproductive endocrinologists across the country. So a pretty big group of people. It started here in the DC metro area and in fact in Rockville, Maryland, which is where my office is and where I do a lot of my work. But it's been when I came out of my fellowship, I sort of wanted to do everything I could possibly do surgically, right? I wanted to do urogynecology, and I wanted to fix people, and I wanted to address all benign gynecologic things. And after 9.5 years of being at GW, where I started, I moved to a group, and I joined a group of urogynecologists who did really phenomenal urogynecology and pelvic floor reconstruction. And I said, I don't need to be doing slings and sacrocolpopexy anymore. They're really good at this. I'll focus on endometriosis and fibroids and hysteroscopic surgery. And I did that for 9.5 years. And about 1.5 years ago, I made the decision to move over, away from, I guess, academic medicine, but join a group, but a really big group that also runs the NIH REI Fellowship is this group here in Shady Grove. And I came on to be their reproductive surgeon. So I stopped doing hysterectomies and I stopped doing myomectomies in 50-year-olds unless they had a donor embryo, right? And I stopped doing, other surgeries that were more geared towards chronic pain or geared towards, heavy bleeding, and was really decided to focus my entire practice on helping women who want to get pregnant achieve their goals in conjunction with the people that help them get there, right? The reproductive endocrinologists. And I am part of this group, but I also, see people from outside, and certainly general OBGYNs in the community still refer to me. Other reproductive endocrinologists in the community still refer to me. But it's been an interesting transition to go from doing all of these different things I've funneled down to now really just doing reproductive surgery. And it's been a real joy.
No, it's interesting. I mean, and I'm glad you're on because it's one of those things we get a lot of questions about surgery and its role in improving reproductive health. I think that it can really vary geographically too, right? Trained in Illinois, where infertility was covered, or IVF. Michigan, it was not. In Kentucky, it's not. I think U of M may do it for their employees or something. But surgically, we get a lot of patients I'm not having success getting pregnant. What can we do surgically? Because it is cost prohibitive for many people to just go straight to IVF, and some people when IVF doesn't work, and so we have REIs we work with and we get referrals from for specific reproductive surgeries. But I guess the big question I have for you is what does that mean, reproductive surgery? And so where is surgery useful? It's a very broad question, and we'll sort of get into the weeds, I'm sure, as we get into this deeper. But what does that mean, reproductive surgery? What are we talking about here?
Yeah, no, I think it's really interesting because on the one hand, everybody who trains as an OBGYN is a reproductive surgeon, right? I mean, we all have to do that. And on the other hand, I think we do a really poor job teaching people what reproductive surgery is and how to do it and how to do it well and how to avoid injuring people so that we don't make their path to fertility more challenging. Certainly, our residencies don't do a great job teaching the ins and outs of reproductive surgery. And I would even argue that our fellowships don't consistently do that, although I know we've improved our educational milestones within the fellowships to really include fertility management in just about every category, whether it's fibroids or endometriosis. But I think there is a huge disconnect between most people that do surgery and actually a real focus on how do we help people get pregnant.
No, I mean, I think in general, we've talked about this on the show a bit, but what was Ted Anderson's number he talked about in his presidential address? 15 months, I think the average OBGYN resident spends during their 4 years of residency doing gynecology. I think that includes GYN oncology, carrying the pager, running around to the ER. It's not 15 months of OR, right? Just learning about gynecology, let alone all the other stuff. And we have surgeons that are doing 5, 6, 7, 8 years and 85% going to fellowship. So forget about reproductive surgery. We've got some work to do when it comes to training surgeons. And so
Right.
You know more than I do as someone who started it and led a fellowship for close to a decade. MIGS is a huge leap forward, or what are we calling it now? Complex
Benign gynecology, right?
When we get more, thinking about how far we've come just in what we know about endometriosis and obviously how far we still have to go. But reproductive surgery is sort of even a smaller niche practice that really I don't think many of us know a whole lot about, or at least certainly most of us haven't had much specific training. Because I think REI is 3 months of surgical training for a 3-year fellowship. Is that still the case? Do you know?
I'm not positive. I think they do get some surgery, but you're right. They're mostly doing IVF, right? And most REIs come out of their fellowship not doing much surgery. I think one of the things that's super important is to be a reproductive surgeon, you really have to embrace and love hysteroscopy, right? We have to be able to do intrauterine surgery at its highest level. And that means, not just using a micro scissors and a graspers, which is what most reproductive endocrinologists will do, or the only tool that we understand how to use is a MyoSure or a TrueClear or some, sort of tissue morcellator, right? We need to be able to be functional surgeons within the uterus as well as within the abdomen. And I think for me, really embracing the hysteroscopy, I love hysteroscopy. And I agree with Linda Bradley when she says the hysteroscope should be the stethoscope of the gynecologist. I mean, it is our way to make a diagnosis and we really should be utilizing it. And sadly, when I sat as president of the fellowship board of directors, I we had to actually let office hysteroscopy go from the requirements for fellowship because we couldn't get the fellowships across the country to commit to making sure that all fellows knew how to do hysteroscopy in the office. I mean, to me, that's just I do 15 of them in a day when I do them, right? I mean, that's how do you make a diagnosis without looking in somebody's uterus, right?
Now, we had Linda on. I think we've had her on a couple of times. We had her on recently to talk about it. And I mean, she is absolutely...
She's passionate.
Very passionate about everybody should get a hysteroscope. I don't care what the thing is, put a scope in there. Are you using disposable or using metal? What's your hysteroscope setup in the office?
I'm very fortunate. So one of the things that I'm very lucky here because I have 2 days a week, I have full access to our ASC. So I can do my resectoscopic surgery. So I can do, today I did fibroids. I did retained products of conception. Last week I did hysteroscopic isthmoceles. I do septoplasties. I do sort of the whole gambit of sort of more complex hysteroscopic surgery right here in our surgery center. And then I also have an office hysteroscopy suite that I can sort of do the awake patients in the more simple types of procedures, a lot of my adhesiolysis procedures, especially a lot of my follow-up procedures to follow people after they're, if I take out a bunch of fibroids, I want to get back in that cavity quickly and make sure they don't develop adhesions, right? And so
you're looking again, second look routine after hysteroscopic myomectomy.
Well, not after everyone, right? If I take out a 1 centimeter type 0 fibroid, I'm not bringing them back. But if I take out 3 type 2 left cornual fibroids, well, that's going to scar. I better get that person back in again. So, and certainly anybody that has a big abdominal or laparoscopic myomectomy, especially that's got a transmural fibroid, 100% of those people I'm bringing back to do a hysteroscopy on after surgery. You bet.
And you're seeing scarring in a lot of these patients?
We actually just pulled the data from the last 15 years. And I think, in my hands, over 17% of those patients who had complex, myomectomies had intrauterine adhesions. And
that's hysteroscopic, that's abdominal, that's all.
No, that's abdominal, laparoscopic, robotic. That's not hysteroscopic.
Gotcha.
The reason it's not hysteroscopic is because we bring those people back much more quickly, right? If I do a hysteroscopic surgery and I do a myomectomy, I'm going to bring them back 2-3 weeks later, right?
Really?
It's quick. Yeah, because I can interrupt that process of adhesion reformation by getting in there quickly. Whereas, if you do a big abdominal myomectomy or you do a big robotic myomectomy and you've just repaired the uterus, you're not going to bring that person back 3 weeks later and stress your repair. I'm going to bring them back 3 months later.
Yeah.
And at that point, the adhesions are what they are. They're there or they're not. But if they're there, you want to find them and address them before that person takes the next step in their attempts to try to conceive.
And you're using a rigid hysteroscope in the office? I'm always curious because we've had trouble where we are just because we don't have hoods. If we want to clean something, we have to send it across the street to the hospital or the OR. So you can do 1.5 day. I mean, it's not helpful, right? And in fellowship, we could do like 6 or 7.5 day as a fellow without even thinking about it because they could turn them. But I'm not sure they're allowed to do that anymore. Anyway, so yeah, what's your setup?
Well, again, because we have an ASC, we have an SPD, and so I own, as a group, I think we've got 16 rigid Batoki scopes, which are the 5x3 millimeter scopes. I've got 2 2.9 millimeter Karl Storz trophy scopes, which I can get through the teeniest, tiniest little space. I've got 3 22 French resectoscopes, a 26 French resectoscope, and 2 15 French resectoscopes. So, and a fluid management system and the whole thing. So I'm very, very fortunate. I've got all the toys. I'm very fortunate. But as a result, and they can turn them, right? So not only do we have the inventory, but as, if I do 15 office hysteroscopies in a day, which is typically what I'll do on any given Friday, we're turning those, the morning scopes are getting turned so that we can use them in the afternoon.
No, and that's, again, I think that's a testament to the value of a high volume surgeon, a high volume practice, right? Like for one person who's doing 80-ish% obstetrics and has a couple cases here and there, like that's not a sustainable system, right? So focusing on that, part of it is someone like you who's worked their entire life to get really good at something, but also having a system set up around you to allow you to work at the top of your degree and your training. So that's fantastic. That's awesome.
Having that and a good support team is like nothing. I never had that in academic medicine. I never had that phenomenal support team. And having it, talk about, improving quality of life. It's just, if you surround yourself with good people, and it makes all the difference in the world. I'm thrilled.
That's all the success I've ever had is, whether it's clinic and finding that nurse who's like willing to put up with me and like build something with me, or the tech in the OR who's now been, for a decade. She and I will do it. She's seen me do it all. But those cases just are better, right? Because it's a team and everything. And so I don't know I think we've talked about this, but as a CMO now, like all I do is try to build teams, right? Try to create opportunities for success, because we have all this talent, but it's not always, organized, set up as efficiently as it could be. So that's very cool. But so talk to me, and we did talk to Linda quite a bit about the hysteroscopic stuff, but tell me the things that you're doing laparoscopically when it comes to reproductive surgery. And are these patients who are all comers? Are they people who failed IVF? Like what are you seeing a lot of? What are the most interesting, and what are kind of the toughest cases you're doing?
Yeah. So, before I came here, I probably was doing 70% of the work that I was doing was endometriosis for chronic pelvic pain, right? So I was doing complex cases, and, I certainly love that, and I still do. But the approach to the patient with endometriosis and chronic pain, and the patient with endometriosis and infertility, let's say failed IVF, right? I mean, endometriosis represents, and when I say endometriosis, I'm even though they're different, I'm really talking about endometriosis and or adenomyosis. That represents 80% of unexplained infertility, we think.
Wow.
And for the majority of those people, great, do IVF and they're going to get pregnant. But for many of them, they don't. And when we look at data on women who we know have endometriosis and women who we know do not, and we put euploid embryos into both those uteruses, we see a 50% reduction in implantation in the person with endometriosis and a doubling of the miscarriage rate in the endometriosis patient. That's a 1/4 live birth rate just from that disease, right? Now, I mean, if you put in a euploid embryo, you should get a 50%, success rate. But if you just have that and then halved it again, I mean, like all of a sudden, these very expensive, very precious, euploid chromosomally normal embryos are failing. That's a problem. We need to address that. And, how can we address that? And it turns out that we can. We can make the diagnosis, and we can treat these people either surgically or medically or in a combination of ways, and really decrease that negative impact that endometriosis and adenomyosis have on this person's success in conceiving and getting all the way to live birth, right? And so for me, many of the patients I'm seeing with endometriosis are maybe have silent endometriosis, right? They didn't show up with horrendous pelvic pain. And I'm going to be a little bit more conservative with that patient than I'm going to be in the patient with chronic pain, right? I'm probably not going to do a low anterior resection for their deeply infiltrative endometriosis if they don't have symptoms. But I will probably treat them with 2 months of pre-frozen embryo transfer GnRH agonist or antagonist therapy to dump their inflammation and to decrease the negative impact that endometriosis has on progesterone receptors.
So help me understand that, because I'm not an REI and don't,
Yep.
We've sort of, I think you brought this up a little bit too, but like sort of divide up my endometriosis patients into 2 categories, really. There's like, okay, chronic pelvic pain. What's the goal here? If it's fertility, like go see the REI. I don't want to mess anything up. So dig a little bit into that, like dive a little bit deeper into like what that means.
Well, right now, but now the REI is like saying, hey, I've got this patient and they're not getting pregnant. I'm popping in euploid embryo after euploid embryo. The cavity's fine. What's going on? And what we know, so I think some of the most interesting data on this comes out of, are you familiar with the Receptiva biopsy? Yeah, so Receptiva is a endometrial biopsy. It actually is performed in the mid-luteal phase of a woman's cycle. And it's an endometrial biopsy that looks for two things. It's looking for chronic endometritis. So it does CD138 testing to look for plasmacytes or plasma cells, which are inflammatory cells. And when that comes back positive, we usually treat that patient with antibiotics for a couple weeks. But they're also looking for BCL6, which is a cytokine. And what they've just figured out is that BCL6, when it meets the threshold of positivity for the Receptiva test, has a 95% positive predictive value for endometriosis.
No kidding.
It's unbelievable. And so now, a lot of these patients, it's been around for about 5-6 years would be my guess. We've got quite a bit of data on it. Maybe longer, maybe a decade. The data's out there. Now, it's really used in the reproductive endocrinology space. It's not like we don't do these biopsies to determine whether somebody has endometriosis if we're going to take them to the operating room. I mean, maybe there's a role for that, but this has really been designed to look at like embryo transfer. And what they know is if you take a patient that has a positive BCL6, and those numbers that I just gave you, about half the implantation rate and double the miscarriage rate, this all comes out of BCL6 data, out of Receptiva data. If you take that patient that's BCL6 positive and the patient that's BCL6 negative, and you put in a euploid chromosomally normal embryo, this is where we see the difference, right? We see half the implantation rate, we see double the miscarriage rate, we see 1/4 of the live birth rate. So that's a problem. Now, if you confirm that they don't have adenomyosis, right? You do an MRI or whatever else, and you say, junctional zone looks great. There's no cysts. There's no pitting when I do hysteroscopy, no adeno. You go in and do laparoscopy, and you excise and get rid of all that endometriosis. And then you do the embryo transfer. You bring them back to baseline. You've basically reversed that negative impact. So surgery that is completely excisional, that's able to get rid of all the disease, reverses the inflammatory or the ill effect of endometriosis on fertility. But it also turns out that you can get the same benefit from 2 months, and most of the data is on Lupron because they've been, the agonists have been around for much longer than the antagonists. But if you give them 2 months of Lupron downregulation prior to frozen embryo transfer, you'll get the same benefit. It will reverse that implantation failure and reverse the miscarriage rates. And you bring them back to baseline. So you can do either or, right? So knowing that, we still keep throwing embryos into these people, but we know they've got endometriosis. And we might know because we took out their fibroids and we saw their endometriosis, or we went ahead and got an MRI to look at their fibroids and they had a thickened junctional zone. Or we don't know, and so then we start thinking, why has this person got recurrent implantation failure, which is a diagnosis, right? In the U.S., that is, or U.S. and Europe have got some different definitions, but I mean, there's definitely a problem of recurrent implantation failure, and that there's something with the receptivity of that embryo. And turns out that endometriosis is often a root cause, and we can address that.
Now, I know you train with Keith, and we've had him on the show as well to talk about adeno a little bit, but talk to me a little bit about when you said you were looking in the uterus and hysteroscopy, and how do you know if they've adeno, or is that laparoscopically, kind of like the mushy uterus? How are you diagnosing adeno outside of imaging?
Yeah, no, I think there's no great way to definitively make the diagnosis. There is, but hysteroscopically, this is the other thing we don't do a great job of, right? We teach our residents, we show them an atlas of colposcopic images of the cervix so that they can figure out all these different levels of carcinoma in situ or whatever when they look at a cervix. But we don't really teach people to look at the endometrium, right? Really look at the endometrium and see what you're seeing. We're not just looking for a couple tubal openings and looking for a fibroid or looking for a polyp. We actually want to really look at that endometrium. Do we see micropolyps? Do we see areas of hyperemia? Do we see stromal edema? Do we see areas that are thin and areas that are thick? Is it a grossly polypoid endometrium as opposed to polyps, but it's sort of an irregular endometrium, right? These are all signs of something is going on that's not supposed to be going on. And it's usually something inflammatory. So what's inflammatory? Well, adenomyosis is pretty inflammatory, right? And if you actually see little indentations, little pits where the endometrium basically dives into the myometrium, that's pretty much pathognomic for adenomyosis. So it's got, a great positive predictive value. But if you don't see it, it doesn't mean they don't have adenomyosis, right? So I can't rule out adenomyosis by doing a hysteroscopy, but I can certainly say, whoa, I'm pretty sure you've got some adenomyosis.
And that one, Lupron, I'm guessing would help more than, obviously.
Right. You don't have a big surgery. We don't have a great surgical armamentarium to treat. If you had Keith on, you guys talked about cystic adenomas, right? And those,
that's a specific, very specific.
That's a very
presentation
specific,
of adeno. Yeah.
Right. We've all had patients that have got, discrete adenomyomas that we can, maybe surgically excise like we're doing a myomectomy or something. But that person with diffuse adenomyosis, resection of that is a hugely morbid procedure. And I'm not saying it's not possible, but it's a Hail Mary at that point, right? And if you can get the same benefit from 2 months of GnRH agonist or GnRH antagonist suppression, I mean, to me, that's a no-brainer, right?
Does that work with spontaneous fertility, or does that work, the Lupron? Because I'm guessing if you're giving Lupron, getting ovulation to kind of come back might be harder than it just saying, here's the drugs, let's turn things back on. What's the data? What's the data on that?
Great question. Sadly, we still don't have a lot of data on like the antagonists, right? But to me, theoretically, the antagonists make a lot more sense, right? They're going to downregulate the axis the same way. But as soon as you go off of it, boom, you're back, right? You don't have the lingering effect of the depot injection. So certainly if I was going to treat somebody who's trying to conceive with IUI or naturally, I'd probably be doing it with an antagonist. And by the way, I would always use add-back therapy. I always use norethindrone, 5 milligrams. There's no same reason we would use it in pain. There's no downside of using it in this setting. The problem is you're going to get that decrease in inflammation, that benefit. You might get a couple months, right? Whereas if I go in and I excise all of their endometriosis, I might have just bought them a couple years of improvement.
So let's talk about that.
Yeah.
The getting it all. This is the conversation I love having my endometriosis surgery colleagues on, because
getting it all.
I've talked about this a bunch, but it's a microscopic disease, right? Like it's, is the cancer analogy maybe good, maybe not. We don't really know what it is, but like we're resecting is a lot of peritoneum, but we're not getting the peritoneum over the sigmoid all the time. There's plenty of peritoneum left, cirrhosis of the uterus, that we're not taking out, right?
Right.
So what does that mean?
I agree with you. I think that there are certainly times, a lot of times, and I think I'm a very good excisional surgeon, but I can't strip 100% of the peritoneum from, somebody's abdomen, right? And you can't get 100% of the disease 100% of the time. I don't care who you are.
Some of our colleagues have maybe said that to their patients, or at least their patients tell me they said that, but we won't name names on this show. But I think that may be an expectation, maybe unreasonable, or maybe they misheard. But I do think that's something we hear about.
Right. But I do think we can get the majority of endometriosis in the majority of patients. And I do think there are some patients, and it's been interesting doing these surgeries. I do surgeries now on women. I get a lot of referrals for somebody that's got a hydrosalpinx, right? And we know that the hydrosalpinx creates an inflammatory environment, decreases successful implantation rates. Well, then you ask them, well, what are the risk factors? Well, I never had an STI. I never had a ruptured appendix. I've never had surgery in my belly. I don't have chronic pain. I don't know. Well, what do you think it's going to be? It's going to be endo, right? And so I talk to those patients and I say, hey, the likelihood is you've got some endometriosis. And this is another issue, even though you don't sort of meet the criteria, or, we wouldn't think of you as an endometriosis patient. Or maybe we would when we actually ask some appropriate questions. And they tell us that they always had horrendous, painful periods when they were younger or whatever, right?
Or just thought it was normal, right? Which we hear all the time.
Or thought it was normal. Everybody told me to suck it up. Right. But regardless, I talk to all of those patients about the likelihood that they might have endometriosis, and that if I'm going to go in and evaluate your tubes and I might remove one of your fallopian tubes, if I see endometriosis, I'm going to take that out as well, because that's only going to improve fertility. And again, that's what I do. I'm a reproductive surgeon. Now, in a lot of those patients, or the patients that maybe did get that receptiva biopsy because they're just trying to figure out what is it that's making it so that my embryos aren't catching, and they get a positive receptiva, I go in on those patients. Most of those patients, I've found disease in 100% of them, but that I've done for that indication. But it's usually stage 1 disease, right? It's not terrible. And so that stuff, I do think I probably get it completely excised, right? I take out right ovarian fossa, uterosacral ligament, little over the rectum. I think I got it all.
It's probably a dose effect. I mean, if you're getting 95% of it, and if the goal is, unlike cancer, the goal is a window of time. Again, we can manage medically this disease to a degree in most patients in ways that will keep them from getting pregnant. But if the goal of a surgery or an intervention is a window of time that allows you to get pregnant, getting some time is actually enough. If it's a 95% excision and it's going to come back, 2, 3, 4 years from now, but we've got a couple kids out of it and we've been able to manage the disease medically and suppress it over the next 10 or 15 years, that's their goal. That's what they want, right? So that's a win.
Exactly
that's
what
absolutely
they want.
right.
Yeah.
So try to think about, when we do the surgeries, we do the why, right? For years and years, all these laparoscopic myomectomies. And I trained at a place where we did those, but also mini lap. And I was like, it's not a very sexy procedure, but like they're getting C-sections. So why are we doing these, all the shotgun incisions? And you can do mini lap, do the whole thing, and they're gonna get that surgery later on. So what are we doing?
If everything goes the way we want it to go, right?
Yeah, right.
Yeah,
so that's at least that's the plan. And so thinking about okay, there are certain surgeries we do that have either a second surgery planned or another intervention, like fertility treatments. So this is one where no, we're not going to carry you forever, but we're going to get you an opportunity to get pregnant in a way that has not been successful so far. And that's something that actually a fellowship program nearby asked me to give a talk on reproductive surgery. And so I spent a few months just digging in, trying to, what does that even mean? The data I found wasn't great. So that's why I was so excited to have you on, because a lot of it is basically if there's tubal disease,
take out the tubes. Right.
And that was the whole thing. I was like, wait, there's got to be more, right? I mean, obviously intrauterine adhesions was a big piece of it too, but the endo question's a tough one. And the fibroid question, let's not forget that either. So we spend some time on endo, but the data on myomectomy for improved fertility, and maybe you haven't looked at the most recent data, but it was never great. It was preterm delivery, and there's certain things, but tell me what the data shows, or what the latest is, or at least in certainly your practice when it comes to fertility and fibroids.
I just, wanted to touch on, the endometrioma, right? Which is the real bane of existence, because while I just got done saying that removal of endometriosis improves fertility, when you excise an endometrioma and you do that ovarian cystectomy, you absolutely diminish ovarian reserve, which has got a negative impact on that patient's fertility, right? And so how do we balance that? And I think these are the discussions, these are the reproductive discussions that you really have to be able to understand and have with your patients that have stage 4 endometriosis. And so, and the discussion I'm having with my reproductive endocrinology colleagues is, hey, can you stimulate this patient? Can you get eggs? Do you get follicles? Do you have access to those follicles? Can you get them, right? Can you do an egg retrieval? Because if you can, let's get as many frozen embryos as we can get now. And then I'll go do that surgery. But what you don't want to do is take out an endometrioma, dump somebody's ovarian reserve, and then start stimulating them to do an egg retrieval, or they're gonna get another endometrioma, right? It's a nightmare.
Scarring and all the things, right? Like,
right.
So that was something for years when I was training. It was get it out for fertility. Then it was if it's a 5 centimeter endometrioma or smaller, the risk
leave it alone.
Yeah, leave it alone. Leave it alone for egg retrievals. Like you said, if it's smaller than that, better to get the eggs out now because the damage to the ovary from the surgery was not insignificant.
And if I can get the same reproductive benefit by doing a 2-month suppression right before that frozen embryo transfer instead of surgery, that's a win. That's what the data is telling us. It's a win. Now, if that patient has pain, well, then you still might need to do the surgery. I'm not trying to talk myself out of surgery. I love doing surgery, but I really, ultimately, my goal is get the patient to where they want to be, which is to be having a family.
And I think that's something that, and we see it all the time, but, as a surgeon, one of the things you learn as you do this a lot is surgery is an option. It is a tool. It is not the answer to all of life's problems. And you do enough of this stuff, you certainly can find some new ones with a knife as well, and understanding what patients' goals are. And that's where office time, and now that I'm only 30% clinical, I have so much more time. I have no productivity requirements now. And so it's just now I can sit and chat and have all the fun I want, having those talks now in ways that when it was go, it was tougher. I imagine, though, in your practice, it's a little of both. You probably have a very busy practice, but fertility conversations are not short, right? I mean, discussions of surgery or not for management of infertility, I imagine some of your visits are pretty long.
A lot of my new patient visits are hour-long visits. I don't pack them in every 15 minutes. And, and that might mean people are going to wait a few months to see me. But on the other hand, I've got a bunch of great colleagues who said, listen, I did the SIS. She's got a 2 centimeter submucosal fibroid. Can you just take it out? And that patient, I could just get right into the ASC, right? I don't even have to meet her first, right? And I'll meet her on the day of surgery, and then I'll send her back to the reproductive endocrinologist. So on one hand, I'm seeing fewer of the people I'm operating on up front, but on the other hand, I'm spending more time on the people that I am seeing up front, right? Because they're more complex.
Are you the only reproductive surgeon in the practice?
I am. It's pretty crazy. I think, a time will come if we get this figured out well, that we'll be looking to bring more in. And I honestly don't understand. It's sort of been a crazy thing that over all these years, I get so many referrals from reproductive endocrinologists when I tried to think of who out there has women's health in their DNA that, wants to hire me. It just sort of made sense that maybe the reproductive endocrinologist will bring me on board.
No, I mean, it's sort of always made sense. When I was in fellowship, I got a phone call from a practice, and I won't say where it was, but it was an REI practice. I'm like, oh, that makes sense. Same, would that be the surgeon? They go, oh, no. We want you to do IVF. I'm like, oh, well, I'm MIGS. It's not REI. They said, oh, no, we know. We'll get you all trained up. And I said, I'm going to pass. In hindsight, maybe it would have been a great gig. But we'll get you all trained up, I think was the quote from the recruiter that I said. I said, I appreciate the, interest in.
Who needs a 3-year fellowship? We'll get you all trained up.
We'll get you all trained up. I was like, oh, well, there's, one way to get into an REI fellowship you didn't match into, but. Yeah, no, I mean, I think it is, I understand why patients are going online, why they're going to social media. I understand why they're looking for answers for management of endometriosis. We have not done a great job of providing those answers in a way that is accessible to not just the patients, but the providers. Like most of us don't. And this is what I do, my practice, right? As a MIGS surgeon, like I see more than 95, 98% of OBGYNs in the country. And I still feel like there's guys like you that are just like, miles ahead, but there's just so much we have to learn. There's just so much more to do. But what do you think and this new test you're just teaching me about that I probably should have known about, But I guess since I don't do REI, I can give myself a pass. But what's the future of endometriosis? What are things if you're in this space and you're tip of the spear here? Are there things down the road you think we're going to be seeing? Is it something that you know much about, or?
It's not something I know a ton about, because I think the basic science is ultimately going to be the answer, right? I mean, certainly the surgery has progressed. We've got neuropelviologists now that are doing, crazy things in terms of pain, and our surgical techniques have improved. But again, I think it's ultimately going to be the medical management that, and our understanding of really what is the pathophysiology of why, why is it that ectopic endometrium suppresses mid-luteal progesterone receptors in the endometrial cavity? Why is that? Like, what's going on there? Why is it that ectopic endometrium has its own aromatase so it can make its own food, right? It can make its own estrogen. Like understanding what these mechanisms are and why they happen is really going to be, I think, the key. And that, the other place where I see that is we've got a huge dilemma right now in women who, and I know you've done talks on intrauterine adhesions and recently did a great talk with, prior fellow from Israel on intrauterine adhesions, and that's another huge part of my practice. But the bigger issue is, like, I can address their adhesions. I can get their cavity back to normal. But what do we do with the chronically thin endometrium that doesn't want to thicken again, right? And why is that? What is it about injuring the endometrial basalis that ultimately leads to a chronic hypomenorrhea and chronically thin endometrium?
It's like dermatology of the uterine lining. There's just so much left to understand.
So much left to understand.
That we don't understand.
We flood these people with estrogen and their endometrium goes nowhere. Why? Because there's no estrogen receptors. They just haven't upregulated. And we don't know how to throw that switch, right? How do you just, because it's constantly upregulating and down-regulating in a natural cycle. But I think the molecular biology of all of this is where this is all going, whether it's endometriosis or thin lining.
Well, luckily, there's nothing in D.C. that's going to decrease our federal funding on things like research for women's health. So we should be good. Yeah, no, it's going to be totally great. Can't wait to see what happens.
And I'm very comfortable. I'll walk out after I'm done here to my car. There'll be National Guard waiting for me. That'll make me feel safe.
It's fine. We were just in D.C. for my college visits for my kids. So we went to Georgetown and GW. And Georgetown, I'd never been to. Holy cow, that's a pretty sweet
it's a beautiful campus, isn't it?
Place. Holy cow, it's amazing. But all right, now I'm taking us to fibroids. I want to understand the impact of fibroids on reproductive health and on fertility. Tell us what you know. Tell us what you're doing. I mean, again, I think we know the submucosal ones a little bit more straightforward, but maybe they're not. So tell me how you approach fibroids in patients who are having reproductive difficulties.
Yeah, I wish I could say that I've got some new insight that you don't have, but I mean, I think at least my approach to fibroids is pretty much what I have been taught, and that is that submucosal fibroids clearly have a negative impact on fertility, and fibroids that are not submucosal have less of an impact. Do they have no impact? That is clearly not the case, and we have more and more data that even subserosal fibroids seem to have some negative impact. Does that mean we should go remove every fibroid that we see in somebody who's hoping to get pregnant next year? Clearly not. People with fibroids get pregnant and carry pregnancies all the time. But, I do think that there's room for sort of individualizing care to the patient. And so if I have a patient that has failed implantation again, let's go back to that. She's doing IVF. I've done an office hysteroscopy. I've documented that she does not have a submucosal fibroid. I got an MRI. She clearly has a type 3 fibroid. It's right there abutting the cavity, but it's not coming in. And it's small, or it's 3 centimeters, or it's 5 centimeters. Does it make a difference? We do have some data that in somebody who has otherwise unexplained infertility, who has a type 3 fibroid that is 4 centimeters or larger, and you remove that fibroid, fertility rates improve. So is 4 centimeters the absolute cutoff? Probably not. What if there's What if they've got a uterus that's just chock full of fibroids and none are coming into the cavity, but they're not getting pregnant? Well, maybe they do deserve a myomectomy. I think you individualize depending on what patients are experiencing, right? And again, my goal is fertility. There's plenty of people out there that are treating the abnormal uterine bleeding or the bulk symptoms and everything else. And, my surgery will do both, but I'm not going to do the surgery if your only goal is uterine preservation and, to get the pressure off your bladder, right? I'm going to do the surgery if your goal is to get pregnant and this is holding you up. And so I just individualize.
Are you doing much for adhesion prevention intra-abdominally in myomectomies? I've seen a lot of different things over the years that people are doing, and I'm always curious to see like what you're doing. Because I don't do anything. Hemostasis, bury my suture, do a baseball stitch so there's no barbs, visible, try to make things clean, smooth, and dry. I don't know what else.
I absolutely agree with you that the number one thing that we can do is hemostasis, well-approximated borders, not leaving raw tissue, not leaving a bunch of suture material hanging out, right? And so doing meticulous surgery with gentle handling of tissue is the number one thing that we can do. I tend to, and this is where you get into trouble because you use your off-label stuff that, you're like, seems to work for me. But I have been very happy with like the fibrin products like Tisseel or Vistaceel or Evasil, because especially with myomectomy, they're hemostatic, right? So, I mean, that's what they are FDA approved for is hemostasis, because they're a combination of fibrin and thrombin. And they aerosolize, so you can coat a surface and they stick, right? So you're not laying a sheet onto something and hoping it stays, right?
Those days.
I hated that, right? And so you can aerosolize this when you are finished. It acts certainly as a hemostatic agent, but it also creates a very nice barrier. And I think, and there have been some off-label studies that suggest that these things also act as adhesion barriers, but it's never been approved for that. And when I dictate it, I say off-label use. But again, I think the most important thing is what you're doing, and that is to do meticulous surgery and do it well.
What about endo resections and thinking about adhesion prevention? That's a conversation I've had over the years with colleagues. Like,
I use the same thing. I still, if I'm going to strip out a bunch of peritoneum, I've got my ovaries pexied up out of the way so I can get into that ovarian fossa or over the rectum or whatever else. At the end of the case, I'm going to aerosolize some of this product. I give it about 5 minutes to set up, and like it creates this like barrier. I put it on the outside of the ovaries, and then I gently let the ovaries go back down, and I get the heck out of town.
Interesting. Never done that or heard of that before, but
yeah,
always looking for something. And that's the beauty of this show, is now this little conversation that we're having may be heard by other people. So let them think about what they're doing.
I'm sure somebody will say that's ridiculous. There's no evidence, and they might be right.
But they probably also don't have a better option for us and for our patients.
I don't think there are other great options, unfortunately. Yeah.
What about fibroid ablation for infertility? That's one of those things that like I started using the transcervical approach because I think that offered me a tool to treat those 1, 2, 3, 4 centimeter fibroids that are there. They're symptomatic, but do I want to have a big laparoscopy and you got to morcellate and put them in a bag and a bigger, can I treat these and avoid a hysterectomy down the road, avoid these things growing? Because before we just kind of watch them until they got much bigger. And then I started thinking about from the reproductive side, like as we're talking, we both know myomectomies are not atraumatic to the uterus, right? I mean, we are hacking these things apart and then Frankenstein putting them back together. And we all think, man, that looks great. But there's a lot happening inside that uterine cavity. UFE makes me more nervous because we're just globally kind of like, throwing some hand grenades. But these fibroid ablation procedures make me think maybe it's a bit more targeted. What are you using this at all? Is this not yet part of your practice? What do you think about all this?
Great question. And I do think I think it remains to be seen. I'm with you. When the transcervical radiofrequency fibroid ablation came along, I thought, man, this is sort of a paradigm shift. This is a great procedure for a subset of patients, right? That 45-year-old with a 5-centimeter submucosal fibroid who's hemorrhaging, right? I mean, it's too big to take out hysteroscopically. It's a type 2 fibroid, right? How are you going to get that thing out? And like, she doesn't want a hysterectomy. She just wants to stop bleeding. That's a brilliant procedure for that patient, right? And for any number of other patients, I think it's a great tool. But am I comfortable treating my IVF patient who with it at this point now? But I'm waiting for the data because, I mean, you've seen the images of 80% volume reduction, right? It's much more focal. You're focusing that energy on the fibroid and not the surrounding myometrium. What I have really had trouble with is there have been many patients that I've seen who have had uterine artery embolizations and they have submucosal fibroids and their cavity is destroyed.
Yeah.
Right. When these things degenerate and fibrose and calcify, like these are people that said straight up, I want to have children in the future. And they were told, this is great for this. And, to me, there's malpractice out there. We should not be doing uterine artery embolization in fertility seeking patients with submucosal fibroids. At a minimum, we should say that. Now, whether we do other ones, I know we could argue that people have gotten pregnant, and who's to say that a big myomectomy is less invasive than a uterine artery embolization? But I agree, the radiofrequency, it's too bad that we can't find enough MRIs to do more focused ultrasonic myolysis, because that's another, world that I think has a lot of
Mr.
potential.
Jephus.
Yeah.
And when I was, talking about that a decade ago, it's a big company, put a bunch of these places all over and they all went bankrupt because nobody wanted one. But
who can afford an MRI that you're going to tie up for the next 6 hours to ablate some fibroids?
Yeah, I know. And we can't even get the MRIs done that we want to get done for the diagnostic ones anyway. But last thing, Isthmoceles. That's something
I'm so happy you landed there.
Yeah. Well, you're welcome. That's one of those things that, like, I'm trying to remember, like, when I first sort of heard about people doing Isthmoceles repair, and it was the idea that it was fluid in the cavity causes inflammation, those kinds of things. When we think about like C-section scar ectopics and in that area, and I've done the repairs laparoscopically on a handful of those, but like, are you primarily approaching those hysteroscopically?
I do them both, hysteroscopically and laparoscopically, and I think it just, again, depends. Obviously, if you could do it hysteroscopically, and the issue is fluid accumulation in the endometrial cavity, and you think there's menstrual trapping or something inflammatory about the scar.
Is that what we think the problem is with Isthmoceles? Because the treatment for it from below is resecting some of the, like, creating an outflow tract. Yes, I mean, I don't do that. It's not part of my practice. Honestly, I just never really have done it from below. But so it's just kind of like,
they're fun. I love them. They're great little.
You just
surgeries.
Shave down. Yeah, talk us through it.
Yeah. So first of all, just there's sort of three things that I think about Isthmoceles creating fluid in the endometrial cavity. So if you're doing IVF and you're getting ready for your embryo transfer, and they're doing, they're monitoring you through that cycle, getting ready to pop in that precious embryo, and there's a bunch of fluid in your cavity, they're going to cancel that, or they're going to try to aspirate that fluid. But there's a reason there's fluid there. Either you've got hydrosalpinx, or you've got chronic endometritis, or you've got bad adenomyosis. All of these are inflammatory. Or you've got a C-section scar that is somehow creating fluid. To me, I mean, those are pretty much the things. Those are the inflammatory disorders of the uterus. I'm giving a talk on the inflammatory disorders of the uterus coming up next week. And those are the things we need to think through strategically. And in anybody that's had a C-section, we can look and see the scar in 100% of those people. But we don't have numerators and denominators because we don't scan them all. So we have no idea what the rate of thin scar, thick scar is. Heck, we VBAC people, we never even scanned them after their first C-section. We don't know if there's a 1 millimeter residual myometrial thickness or if it's a centimeter. We just say, yeah, let's try a VBAC and see what happens, right? So we don't have the data on, to really say what the incidence is. But what we do know is that these scars can form in a way that they absolutely can trap menstrual flow. And we see patients have menstrual irregularities after their C-section, right? Post-menstrual spotting, dark blood coming out, pain with their periods that they didn't have before. So we definitely know that the orientation of that scar can be trapping. And if it does, that fluid can flow back into the cavity, just like a hydrosalpinx works, and now you've got inflammation in the cavity. But the other thing is, any scar can be inflammatory, right? You can see granulation tissue at the vaginal cuff. You can see, healing tissue that's inflammatory. And if you put your hysteroscope into that scar, sometimes you actually can see inflammatory frond-like tissue coming out of that. And you can excise that tissue and improve things. But the other thing is, where does cervical mucus come from? Well, it comes from the cervix. Where's the isthmocele? It's in the upper cervix. You are tapping into mucus-producing glands. And when you repair this and put it all together, how often is there mucus coming straight out into that scar? Is that maybe the reason it didn't heal so well? And I'll tell you what, if you're paying attention when you go in with your hysteroscope, you will often see mucus right in that scar, and you can track it right up into the endometrial cavity. You're not supposed to have mucus in your endometrial cavity. But if you look, you'll see it. So mucus-producing scars, inflammatory base, menstrual fluid trapping. All of them can play a role, I think. And in a scar that's not too thin, right? You're not worried that you're going to bust out and hit the bladder on the other side, right? So 3 or more millimeters of residual myometrial thickness. And that's not too volumetrically huge or it doesn't have a ton of cystic components all around it. Bringing that scar into continuity with the endocervical canal does have a significant impact. And you can improve that fluid in over 80% of people by doing a hysteroscopic revision. There was actually a really interesting study that I pulled up off of, I think it came through one of the hysteroscopy SIGs or something like that. But it was a Asian study, I think it was Korean, but they measured the volume of isthmoceles before and after hysteroscopic isthmocele revisions. Now, to me, that's a no-brainer, right? They're going to be bigger after a hysteroscopic isthmocele revision. It's not what they found. They found that volumetrically, the residual myometrial thickness got thicker, the overall volume got less, even though they took tissue away. Why? Because they're not trapping fluid anymore? Because it's not, I don't know, but they actually—
It's repairing itself, yeah.
It's repairing itself. So they did hysteroscopic revisions and demonstrated that the scars got smaller, even though they resected tissue. I think that's fascinating.
Wow. Amazing.
Yeah. Anyway, yeah.
Well, look, you're a wealth of knowledge. You're also a super fun guy to hang out with, and I'm grateful for our friendship. But I loved having you on the show. I feel like we could go on for hours and hours, and we also need to have some things to talk about when we see each other. I'm assuming you'll be in Vancouver, hoping you'll be in Vancouver.
Will be in Vancouver.
Now that you're a big reproductive surgeon, you're going to have to start going to ASRM instead. I'm sure they're not nearly as fun as us.
Not as fun, not as fun. I'll stick to the, reproductive surgery, but I don't think ASRM is really going to be for me.
Perfect. Well, no, it would be the same without you. I'm glad you're going to be there. I'm looking forward to a good meeting this year, but it's always a pleasure to get you on. That was awesome, man. I really appreciate you sharing what you're doing, your practice, and it's going to be a good one for our listeners to get to hear all the things you're doing. So thanks so much for making time. I know you're a very busy guy, and for making time for us, I say thank you very much.
Mark, it has been a pleasure, and it's been a good run that we have had over the years, and it's really fun to watch people that grow up through their careers. We were pretty young when we started this whole process, but
we've done okay. We've done all right.
There's less hair here than there used to be, but we're doing all right.
I think I told my dad, it's not that you don't have a lot of hair; it's you have a lot of face. I said, so I've got
lots of face.
All right, man.
Perfect.
Well, have a great evening, and thanks again for coming on. We'll talk soon.
Thanks so much, Mark.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.